Hello and welcome to the program, Dr. Joe, where we discuss various health issues affecting humanity at large. Today we are going to be discussing epilepsy. By definition, epilepsy is a neurological condition that is characterized by abnormal firing of action potential in the brain. Action potentials are the nervous impulses from the brain that stimulate your body. If you want to move your upper limb, it will tell you to move your upper limb. So when you've got epilepsy, what happens is you're firing those action potential in an abnormal way, in such a way that you can't control and decide using your brain to move your limb like this. The action potentials will be deciding for you to move your limbs in a way that you can't move your limbs on your own because of the abnormal firing of the action potential. The prevalence of epilepsy is about 0.5% of the world population. That comes to about 39 million people are affected by epilepsy. When it comes to the mortality, the number of people that die of epilepsy per year is about 125,000 people annually that die of epilepsy. This is from a study that was done in 2015. The causes of epilepsy are generally idiopathic, that is, it's unknown. That's most of the patients with epilepsy, the cause is unknown. For a few patients, the cause is well known, e.g. strokes. You could also have brain tumors, you could also have brain trauma, you could have brain infection that could result in epilepsy. In the cases that we have where you know the cause, you manage the cause. If it's stroke, you manage the stroke. If it's a brain infection, you manage the infection. If it's a brain tumor, you manage the tumor. If the management of those other causes is well done, then that means the epilepsy becomes well controlled and the patients can be weaned off the epilepsy medication. But in the idiopathic cases, that is those cases where the cause is unknown, generally most of the patients will need to be put on treatment for life. Thank you for watching the first segment of epilepsy. Join us after the short commercial break as we go on and further discuss the causes of epilepsy and the management of epilepsy. Welcome back to your program, Dr. Joe. We discuss various health issues affecting humanity at large. And today we're focusing on epilepsy. We've touched on what exactly is epilepsy, who is affected by epilepsy, how many people in the world are affected by epilepsy, and we also looked at the causes of epilepsy. Now we're going to look at the types of epilepsy. There are a minimum of 4 types of epilepsy that we generally classify according to the types of seizures that people suffer from. The commonest type is what is called tonic-clonic seizures. These are the types where you get a patient when they suffer from the epilepsy, the attack comes, they become prostrate, the limbs are extended like this, and for about 10 seconds. Then after that, they start having some jerky movements. So the extension is what we call the tonic phase. Then the jerky movements, we call them the clonic phase. So that's one type of epilepsy and is the commonest type. Then from that one, we get to a certain type that is just called tonic epilepsy, where you just get prostration or extension of limbs with the back extended as well without movement, that is jerky. That is called the tonic type of epilepsy. Then the clonic type, you just get into jerky movements without any prostrate phase before the jerky movements. Then after that, the 4th type is called the petit mal or absent seizures. These are the type of seizures that are difficult to diagnose. Just get a patient who gets what is called a stare. They just become absent of the environment. They just open their eyes and look like this without moving. In those cases, usually it lasts for maybe a minute or so. Then after that, they go back to normal activities. But during that state, they want to know what exactly was happening, what was the problem. If you ask them what was happening, they want to know what exactly happened. Now let's get deeper into the tonic-clonic phase, a type of epilepsy, which is the commonest type. In that type of epilepsy, what actually happens is when the patient is fitting, one, they don't know what exactly is happening. Then after that, they also have what is called eyeball rolling. This is very classical of epilepsy. And if you want to compare someone with epilepsy and someone who's fake epilepsy or not real true epilepsy, you see that the ones who do not have epilepsy will be don't have the eyeball movement. But with those with true epilepsy, they have eye rolling. Then 2, they also have what we call tongue biting. But tongue biting, even people that fake epilepsy can actually bite their tongue if they know it's one of the symptoms. But you will see the extent of the bite. Usually the bite is actually either on the front of the tongue or on the sides, this side or the other side. That's normally where you get the bites. So those 2 things, eyeball movement and tongue biting, are classical and typical of tonic-clonic seizures. Then after that episode or that period of fitting, usually they get into what is called a post-ictal state. In that state, they are just lying prostrate, they are not fitting, but they don't know what exactly is happening. Usually that state lasts for about 10 to maybe up to a maximum of 30 minutes. In that phase, usually you've got relaxation of sphincter muscles. They can defecate on themselves, pass stool on themselves, they can urinate on themselves, they can actually even be drooling as well. After that time, that's when they come back to the normal state. That's what happens with the tonic-clonic seizures. With the petit mal or absent seizures, usually it's just a stay that just happens for a minute or so. Then after the stay, the patient just gets back to normal soon after. With the tonic form of seizures and the clonic form of seizures, the effect is similar to the tonic-clonic seizures. You get a post-ictal state that affects you soon after the seizures. Then prior to the seizure, you get what is called an aura. An aura is a feeling or a sensation that I'm about to have a fit. And when you get that feeling, usually the fit comes within a few minutes after the aura that you have experienced. The aura comes in different ways. You can have a feeling of blurred vision, you can't see properly, and you can have a feeling of nausea, you want to vomit, or a loss of taste sensation, or you could be hearing funny sounds, and you know that your symptoms are about to happen. When you get those symptoms coming to you, then you know that the fits are about to come. Unfortunately, during that time, it's difficult for you to do anything to prevent the fits from happening. You'll see when we discuss migraine next week, and you see the difference between migraine and epilepsy. Now, when it comes to the diagnosis of epilepsy, one thing that I need you to know is diagnosis of epilepsy is mainly clinical. By clinical, it means diagnosis is from what you tell the doctor or what the doctor sees or whatever was the eyewitness is telling the doctor. That's what we use to diagnose epilepsy. One, if you've got fits or you've fitted or you've had seizures 3 times, it means you've got epilepsy. That means if you fit today or you get a seizure today and then you get another one another day and the 3rd day, it means we diagnose you of epilepsy. No matter of how much you've been fitting, maybe you just had a solitary fit or a small fit, but usually we diagnose epilepsy once you get 3 or more seizures. That's how we make a diagnosis of epilepsy. To aid the diagnosis of epilepsy, there are certain tests that we also do, and there are also tests that we do to rule out other conditions that can mimic epilepsy. One, a gold standard in diagnosing epilepsy is what is called an EEG, electroencephalogram. When you do an EEG, it will show us the electrical activity in the brain. And if you've got abnormal electrical activities in your brain, we diagnose you of epilepsy. But I need you to note one thing. It doesn't mean that if we do an EEG and it's negative or it's normal, you do not have epilepsy. I want to repeat this. If we do an EEG on you and it's negative, it does not necessarily mean you do not have epilepsy. What does it mean? It means that at the point of doing the EEG, you are not having abnormal focal epileptiform fits in your brain. So if we take an EEG at the time when you are not having the fits, the EEG will be normal because the fits are not always there. The abnormal electrical activities is not always happening in your brain. But when you take the EEG at the time when it's happening and it comes back and it shows that you've got epilepsy, definitely you've got epilepsy. So I want you to note that. A negative EEG does not mean you do not have epilepsy. The other tests that we do to rule out other conditions include, one, a CT scan of the brain. We might need to do a CT scan of the brain to see if you do not have a brain tumor. We said it's one of the causes of epilepsy, like the secondary cause of epilepsy. So if you've got a brain tumor, we'll pick it from a CT scan. If you do a CT scan of the brain, we'll pick a brain tumor. If there is no brain tumor, we can pick other problems that could be causing the fits. Then the other tests that we do are blood tests. There are things that we call biochemical derangements that can cause fits. So if we do blood tests to look at the functionality of your kidneys, if the kidneys are not functioning well, it can affect your brain and you might have epileptiform fits. And when you do those tests, you can rule out those causes of fits. Then also get to do other tests like MRI scans to rule out any possibility of other infections. Then you can also do a lumbar puncture. I want to focus a bit more on the lumbar puncture. There's a myth and there is always talk in the street about a lumbar puncture being very deadly or it causes death. I want to demystify that. Lumbar punctures do not kill people. Lumbar punctures are actually diagnostic. They help us make diagnosis, especially if we think someone has got a brain infection, say meningitis. We do a lumbar puncture, we get the diagnosis, then we treat the brain infection and the person is free from the fits, because some forms of meningitis can also cause fits. So if someone is having fits and the doctor orders a lumbar puncture, please cooperate with the doctors and allow your relatives, or if it is you who's been ordered to have a lumbar puncture, just allow the doctor to do their job, and that way you'll get some assistance. Thank you. We've come to the end of the second segment. Join us shortly after the break as we discuss the management of epilepsy. Now let's get a look at the complications of epilepsy. Complications associated with epilepsy essentially come from the fitting that you get or the seizures that you get. When you get those seizures and you're fitting, that's when you get some complications. One, the patient that fell into a fire. This guy was a guard by a farm, and he had these fits by himself. He had a fire at night, and he fell into the fire, and he bent his entire upper arm and lower limb through the fire. And it was because of the fits. And after we managed him, we had a difficult way of controlling the fits and also to manage the bends and the infection that had arisen from the bends. So that's one complication that you can get. When you fit, you can fall into a fire. And when you fit, you can also fall into a river, or you can fall into a pit, or anything can happen to you. If you're a driver and you develop a fit, you can have an accident. So what we normally say, if you've just been recently diagnosed of epilepsy, we restrict you from driving until we've seen that your epilepsy has been well controlled for a certain period of time. We can give you 3 months, 6 months, depending on what your doctor thinks, depending on your condition. We might restrict you from driving by yourself or from driving altogether. We encourage you to stay with someone who can help you. In terms of a fit, they can help you and pick you. Say you fall into a fire, they can help you and drag you from the fire as soon as possible. Maybe if you've got a fit and you fall and you're by yourself, they might know the medication to give you so that you are well protected and well covered before they take you to the hospital. So it's always very important, if you're epileptic, that you stay with someone. Never stay alone, so that you get protection and cover. And in terms of emergencies, if someone develops epilepsy, they have a fit, please take them to the hospital as soon as possible. It's always important to take patients to hospital as soon as possible, because at times people develop a fit now and you keep them at home. A few minutes or hours later, they develop another fit, and that will be worsening the prognosis, the outcome of their condition. So it's very important to take the patient to the hospital as soon as possible. Epilepsy also comes with some social issues, e.g. stigma. You get a case where a child that is epileptic is not taken to school because of the epilepsy, or their colleagues, their friends at school, they laugh at them, or families. People can actually stigmatize the entire family because of epilepsy. Believe you me, being epileptic is not a problem. You can become anyone. You can become a doctor, a lawyer, a businessman, a politician, and a leader in any way with epilepsy if it's just well managed. There is no need to stigmatize people with epilepsy. There's no need to stigmatize families of people with epilepsy. There is no need to sideline or marginalize people with epilepsy. They deserve equal opportunities. They deserve to go to school. They deserve equal exposure that is given to everyone else. So anyone with epilepsy, they need to be covered and they need to be taken care of. They need to get their medication and they need to be given social support. In conclusion, we want to recap on the important things pertaining to epilepsy. One, when you are diagnosed of epilepsy, that is when you've got 3 or more seizures, please go to the doctors and get diagnosed. When you get diagnosed of epilepsy, please make sure that you follow what the doctor says. If you're put on medication, take your medication, and do not stop taking your medication until and unless when the doctor says so. And when it comes to social issues, please, please, please do not stigmatize against epileptic patients, because anyone with epilepsy is just as good as anyone else. There is no need for discrimination of families or individuals with epilepsy. Thank you for watching the program, Dr. Joe. Today we've been discussing epilepsy. I hope you learned 1 or 2 new things that will help you manage epilepsy and help you help the community at large. Next week we'll be discussing migraine. And before you go, remember to click the subscribe button on the bottom right corner, and remember to like and to share the episode, and also follow and like us on droptv.com, and also like Dr. Joe on Facebook, Instagram, and Twitter. Thank you for watching.